Hi, everybody. It's Kevin and it's Donna from the Deprescribing show. My get up here is in celebration. We've got college football starting, Donna, and this is my last year of Pac 12 WSU action. So I'm going to try to soak it up as much as possible. And we have a really exciting episode for you on soaking up some antibiotic stewardship kind of components and how it kind of intermixes with what we have going on in Deprescribing. So stay tuned. We'll talk to you in a second. All right, Donna. So good to see you. What's been going on inside of the career? Are you just changing everything happening inside of ALFs?
Oh my gosh, I am trying. I just got some great new material to send out, and
Sweet.
it's really thinking about what can we change, right? What can we change as pharmacists? How do we change the mindset of folks who are most likely over medicated? So trying to add a little bit of education in hopes that they really start thinking about, wow, we really need a pharmacist here. So yeah, so between reaching out to them and working with some folks on the Massachusetts Assisted Living Association toolkit for falls prevention, it's been pretty exciting to kind of see that grow.
Man, I'm so excited for that. I just posted, Donna, about listening to a gentleman named Kealu Fox. I don't know if you follow Kealu, but just an incredible mind. But he really went into some like incorporations of indigenous ways of like healing and learning and applying those methodologies to like technology and innovation. And it really had me thinking like, what Kevin have you encountered that you feel like just needs a reevaluation? And the first thing that always comes to my mind when I think like carbon footprint in general is drug waste. And so I talked in the post a little bit about, here's a huge problem with this fake word of expired and how it's not true and how we need to reevaluate the way we're doing these mandates. But the other piece I didn't talk about, which I hope you and I have a chance to sometime, is the amount of unnecessary surplus that a lot of these individuals in an ALF setting just have so many mail order and or prescription drugs that are sitting and being unutilized.
Absolutely. For
And
sure.
oftentimes one of those is antibiotics. Like it's crazy that's actually the case. But so many, drawers I've gone through, their antibiotic load is unbelievable. They've got something from every cephalosporin class and every penicillin you and I have ever thought of.
Absolutely. I know. And it's just, and I always say to folks, what do you have in your medicine cabinet? Do you have old pain relievers, old muscle relaxants, old antibiotics? I really hope not, like don't keep those.
Oh man. And without further ado, I'll jump to your first slide.
Yeah, awesome. Thank you. So we just, thinking about our older adults, it can get dicey, of course, right? There's a lot of comorbidities and medications, and now they need an antibiotic. It's not just the go-to that we can just go to. We got to be super careful about this. And this is just a really important case highlighting a pitfall, if you will, of inappropriate antibiotic choice because of comorbidities and what this patient is going through. So we can move forward. So we have our case DS, and it's a 74-year-old female, and she ends up in the emergency department, and she's really complaining about fatigue and dysuria. And this has been going on for about 6 days. She had called her PCP, and there was definitely a UTI, and so testing had come back, etc., and she was very symptomatic. So treatment did need to happen. She was very uncomfortable and having a lot of urinary issues. So, she started on sulfamethoxazole trimethoprim, the double strength, and it was a day before her coming into the emergency department. So she comes into the emergency department. We know that she has a history from past issues of hyponatremia, and she is experiencing that now in the emergency department. Esophageal reflux was just another term for GERD, basically. Hypertension, hyperlipidemia, type 2 diabetes, depression, and hyperkalemia. And then problems added to this is, of course, the UTI that she's experiencing. So we're going to move forward with this, and we find out that these are the meds that she's taking, and there's 12 of them listed here. So all of a sudden, right, we already have that polypharmacy, and we're looking at this, and her anticholinergic burden we know automatically is over 3 because she has oxybutynin, which is 3 points, and then she has other products such as like the venlafaxine and other sleep aids, etc. So there's already an issue here, and we know that there's problems, but we're really thinking about like what's going on. She ends up having acute kidney injury, AKI. Then that's part of what this hospitalization is occurring. So we're going to go to the next slide with the labs. And with this, her potassium's high. It's 5.5. So she's getting into trouble here. Sure, sodium's low. I put up her last lipids profile just so that we have that for another bit of the talk. Her creatinine clearance is her creatinine, actually, excuse me, that's not clearance, it's her creatinine, serum creatinine that is elevated. And her blood glucose in general is throughout the hospitalization has pretty much stayed within this range. So now we're really getting into trouble here with this patient, and it is a good thing that she actually came to the emergency department. So what is it? And we can go to this next slide and see what's going on and what are some of these medication issues. So we can see that the sulfamethoxazole trimethoprim, it's actually considered a Beers criteria medication. And I don't know if people realize that, that it's an antibiotic. And, we think a lot of chronic products, chronic disease state products, but also a lot of the pain relief and benzodiazepines and things such as that, anticholinergics. But here we have an antibiotic, and there are plenty of antibiotics that are actually, could be some problematic ideas, if you will, for older adults, whether it be post-use or during use of the products. So a lot of drug interactions too, of course. So here we have this, and we know that there is a reduced creatinine clearance that occurs with sulfamethoxazole and trimethoprim. And there's also a risk of hyperkalemia. Well, our patient is also taking an ARB, otherwise a losartan is the product that she's taking. And this occurrence of the hyperkalemia occurs more in patients that are taking an ACE or an ARB, of course, because those are potassium sparing products anyway. So we kind of have a perfect storm going on here, if you will, with the antibiotic and with the products that she's taking. We have seen that she doesn't have the best creatinine clearance when she comes in. Her serum creatinine is already elevated from previous lab values that she had in the past. So we can really see that there's some injury that has occurred here. Other risk factors are that that might cause hyperkalemia for this particular patient, which is really such a big problem for her, is reduced EGFR, which she, of course, is having, her age, that fact that she's an older adult, and that she's had a previous incident of hyperkalemia in the past too. So right there, we have to be super careful. And as stated already, she already is taking a medication that has the risk of hyperkalemia. So right then and there, that choice of using um, the sulfamethoxazole trimethoprim is not really an appropriate medication. And it's fast for this person because she's probably has been kind of on the line anyways for the higher normal end of potassium. So we're really getting into trouble here. So
Wow.
we can move forward. So what happens in the hospital is they hold, of course, um, I didn't put it up here because she didn't have the antibiotic with her. So they
Oh,
didn't give it. They held that. So that wasn't even on the list. Gemfibrozil was held as well as the losartan. Um, Omega 3 and zolpidem were both stopped um, during the hospitalization. Not exactly 100% certain as to why that is. It wasn't added on
okay.
in the meds that she was taking, which is fine. I think the omega 3 was probably, and I take this back, the omega 3 was probably held or stopped because she did have some blood in her urine, part of the UTI that she was symptomatic with, and zolpidem, they weren't giving it to her in the evenings. Her blood pressure was also very, very low, so
Mm,
holding the losartan makes sense as well. So she was very dehydrated and just she wasn't well when she came in at all. So those are some of the things that were held and what was going on in the hospital. So when she was discharged, she ended up having the losartan, omega 3 and zolpidem. They were all stopped, and she did not go back on them because her blood pressures were still normal to low. And so adding on that, and then the potassium levels were just barely over um the high side of things. They were just coming down to the normal high. So
got it.
certainly appropriate to not continue the losartan at that point in time. But the gemfibrozil is still really interesting because
Hmm.
gemfibrozil is something that should not be used during um, especially AKI or acute kidney injury, but it's also something that isn't really necessary. And what is the purpose of this medication for her? It's something that she's probably been taking for, I'm assuming, at least 10 years from what I could see. And if you go back and look at her um, her lipids are actually good. They're not terrible. And the worst thing that is probably um, still a slightly elevated, but it's not that she's had a previous MI or anything, but the
Yeah.
LDL, it's under 100. But if you look at kind of the number compared to the total cholesterol, it is
Right.
rather high for
Mhm.
that ratio, if you will. However, um, the omega 3s were on. And we know that omega 3s, fish oils, they can increase LDL or prevent LDL from being lowered. So, already by stopping the omega 3, we can be hopefully reducing the LDL. She's already on a torvastatin 20. So, she already is getting this lipid lowering action. And then the triglycerides of the 125, that is excellent. It's not a bad number at all. And it's been that way for over 5 years. So
Wow.
why are we keeping the gemfibrozil on at this point when it really is not appropriate
Yep.
and probably shouldn't be put back on because of the acute kidney injury that she has just endured, and her kidney function was not really back to normal 100% at discharge. So she did go back on the gemfibrozil at discharge, and I just don't agree that that's something that should have been a part of the outcome,
What
if
was the
you will.
justification, Donna? Just those
So
triglycerides?
yeah, as to why she was taking the gemfibrozil, is that what you
Why
mean?
they put her back on?
They just held it while they were her kidney function did come back up. It wasn't back to 100% normal, but it was at a level that you could actually put the gemfibrozil back on.
Okay.
So it wasn't below 30 when you shouldn't be recommending it at all. So I think it's one of those things that, we're not going to touch it cardiovascular wise. We're not going to touch that medicine. And it's safe for her to use it again. We don't have to, necessarily change that. So it's something that could definitely have been deprescribed, but was not, because of, maybe perceived um, information, if you will, and not wanting to mess with medicines that had been on for 10 years and they weren't necessarily a part of the initial problem. They just had to be stopped during the problem.
I can't agree more with Kate. I think you probably saw that, Donna, that just came across that Kate
Mhm.
Shaw just said no with multiple exclamation points behind it. Um, that's what I was worried about. I thought, did they put it back on for a reason, or did they just refuse to take it off? And
Exactly.
that
Yeah.
component right there is just it's heartbreaking to see a drug go back on that has
Yes.
really no efficacy standpoints, no real benefit to the individual patient, and has a high likelihood to give other problems in the near future.
Yes, absolutely.
Darn it.
So, yeah, so definitely, issues, if you will, um, with this list and trying to make these changes. So, so let's move forward to the next slide because, this was an acute issue. We definitely, some things did go off, which is great. Some more should have. But these are the things that I think that should still be addressed for this patient moving forward, because as we know, we're probably not going to take care of every single issue in one encounter, if you will, with deprescribing. These things take time, and so I do think that more needs to be addressed here. And here are some of the things to be addressed. One is that gemfibrozils, let's try to get that off, or convince the docs that, let's stop it and see if the triglycerides go back up, if they were ever like super elevated. And they've been remained at a great level for some time. And then the atorvastatin, I think we can totally keep that on at this point in time. But if there's side effects, if taking off that omega-3 helps reduce the LDL, we might not have to be treating so aggressively. Maybe it could be cut back some if needed. I still think that, there's probably some assistance that is that the atorvastatin is probably doing, but definitely something to be continued to be looked at as we make these changes. The oxybutynin, she's not necessarily on medications that could cause incontinence at this point. So trying to figure out like what's going on there. And if it is more um, like mechanical or muscle, there's so many other treatments that can be used, and there's physical therapy treatments and other training that can occur so that maybe oxybutynin does not need to be continued. So I would be looking at more of the non-pharm approach to the oxybutynin versus the oxybutynin for incontinence. So that would be something that I would highly consider in moving forward. So those are just some, other thoughts. And of course, just continuing to work with the patient. But as you can see, if we can eliminate some of these things, we are really reducing the number of medicines for this patient. Um, so she could end up just on 6 meds. the whole GERD issue, trying to get some more information on that. Didn't quite understand if she's on it twice a day. I think it's too much for that too. But I wasn't able to necessarily reason the need for the two or see any results if there was any esophageal damage that might have occurred because of esophageal reflux. So trying to find that and wasn't able to find that. So I'm thinking omeprazole is probably something that can be tapered off slowly as well.
Wow. A number of just little nuggets and pearls of wisdom inside of this individual case. I think the omeprazole is a really interesting one for lots of reasons. Like you and I have seen, if it's either related to microbiota or if it's related to just acidic load, but omeprazole and
Mhm.
being linked to several things, including increased risk of pneumonia for folks, is a fascinating element to talk about during our antibiotic stewardship episode.
Mhm.
Another one that was really fascinating is seeing like venlafaxine and seeing zolpidem, which was taken off of there, and some of the
Mhm.
problems that you get with drug interactions of something like zolpidem being on board and adding on an antibiotic to further heighten that and increase the risk of fall for an individual. So one big element of saying, hey, guess what, Mr. or Mrs. Jones, we're going to put you on this antibiotic, but we're not going to talk to you
Mhm.
about the other medications you could be taking that now are going to become very problematic because you're taking them PRN, or in this case with venlafaxine that is scheduled. The other ones to me, Donna, that I'm really curious, especially with the sulfamethoxazole trimethoprim, at least in our communities that I was working in, and I've seen it somewhat globally, the antibiotic resistance to sulfa and sulfamethoxazole
Mhm.
trimethoprim pretty
Mhm.
significant in general, just in
Mhm.
using the drug and seeing an actual impact for these groups. When it came to
Right.
just evaluating that antibiotic selection, any thoughts there, Donna? And I didn't know if the infection was cleared up entirely and that's why we moved away, or if there would have been another choice if it would have continued.
No, they ended up using ceftriaxone in the hospital for her, which ended up being appropriate. And by the time um, they'd done more cultures and she was fine at the end. So she was doing much, much better. And like I said, her kidney function was returning, potassium was lowering, the sodium was coming up slow but sure, still low, unfortunately. And that might be due to SNRI too. So there's so many things going on with this particular patient, and really trying to optimize meds. It's almost like could just start all over.
Yeah, I mean, that's an
Yeah.
interesting potential drug holiday opportunity here when it
Yeah.
comes to this patient. The one thing I wanted to ask, just to tease a couple other things out of it, we did
Mhm.
talk UTI in a previous episode. Everybody go back and check
Mhm.
out the YouTube channel and kind of look through that. But a
Right.
couple little nuggets that I was looking at before we started the show was the VA study that was done, Donna. I think it's now like 4 or 5 years ago, that they were
Yeah.
showing like which drugs are the most likely in the antibiotic realm to have a severe kind of related incident. And you guessed
Mhm.
it, sulfamethoxazole trimethoprim was
Yeah.
the top of the list. The
Yeah.
next ones, interestingly, were ciprofloxacin and fluoroquinolones. Looking at
Mhm.
those in general, just those
Absolutely.
causing other issues related to nerve
Yes.
pain, muscle pain, other
Yeah.
weakness, like types of issues, and
Yeah.
overall drug interactions. So,
Right.
talking about that, UTIs in the elderly, treating them with antibiotics, I
Mhm.
always go back to the hospital days of just thinking, if we could just inject everybody with ceftriaxone, it seems like a much better
Yeah.
alternative so often than exposing
Absolutely.
someone to 3 to 7 days of any other agent.
I know, and it's true, and don't forget, like, if you wanna treat if symptomatic, and in this case, obviously very symptomatic,
Right.
so necessary, but don't just treat just to treat if somebody's confused, and I think Dr. Michael Bear was really great with sharing his information with us and what
Yes,
he tries to do in the hospital setting. So for sure.
I love it. Well, let me pull this guy down real quick. Any other things, Donna, that you've kind of run into over the years? Any pearls of wisdom when it comes to just hitting general antibiotics and going, oh boy, like we're going to have to think
Yeah.
about this differently because we're dealing with a much more vulnerable and susceptible individual. We just can't throw it on board.
Right. So I think the other thing, and it might not be as big of an issue as it was because we're not using as much warfarin, but when you're thinking about the effects of the INRs that antibiotics have on INRs, that was always very significant. So
Mhm.
always telling folks, you probably need to get your INR checked within 7 to 14 days. So that was really important with the fluoroquinolones and also with the Bactrim too. So that was very important things. We also see some issues with, um, I believe it was with some of the sulfonylureas. I know that we're not using those quite as much either, but there was a lot of interactions with sulfonylureas and also with antibiotics as well. So things to be aware of in our selections. And then also, I know that it's hard to predict, but the um, the issues with the tendons with the fluoroquinolones, that can really be a problem. And I've seen that happen before. You hear stories of folks that, oh, my mom was in the hospital, had a UTI, whatever goes on and on. And then she ended up, tearing her tendon, her Achilles tendon was
Yeah,
torn or something. And you're like, oh, did they use, ciprofloxacin for that for that UTI? And sure enough, that's what it was. And they'd be like, how do you know? And so but hard to predict who that is going to be.
right.
But things to totally be aware of for sure.
That was definitely my one of my nuggets right there was just the tendon rupture kind of component. The other one
Yeah.
that I think is interesting that you come across much more often than you would maybe think, or maybe most of our audience knows this is the case, but is C. diff. Seeing that in our elderly folks of starting them on in a antibiotic regimen, and then there are problems with just I'll call them what we could did in the hospital, vitamin V and vitamin P. When you're looking at or Z, depending on your hospital, but
Mhm.
looking at vancomycin and Zosyn or Piptaz, like it's really interesting to see the number of issues that pop up. Vanco is one that's really easy to think of because we know about the creatinine clearance and the
Mhm.
kidney clearance and some of the problems that can ensue based on
Mhm.
that gathering in the body. The other pieces
Yeah.
that I think are really interesting, Donna, with C. diff is just paying attention to what we're actually treating C. diff with. I know in the elderly, we're saying, hey, we want to keep these regimens uh, fairly simple, but make sure you've updated yourself on are we using which drug for these folks when they're going outpatient and which formulation is it being
Yeah.
used in? That is still a
Mhm.
very common error, to end
Right.
up happening
Right.
in an outpatient setting.
For sure. Yeah, so there's just so much. And then also, like we talked about too, Kevin, that whole proton pump inhibitor and what that does to flora and other potential increased risk of infections that we see. So lots to be thinking of, thinking about C. diff as well as the pneumonia.
Definitely. Love it. Well, thank you so much, Donna, for all the insights and another
Yeah.
wonderful case. It's so funny. You look at a drug regimen like the one that we have here. Let me just put it up real quick for folks to see one last
Mhm.
time. But I mean, once again, it's so common, to see a drug
Yeah.
regimen just like this and all the problems that can ensue without
Mhm.
appropriate monitoring of what is this being used for? Is it still necessary? Is it causing benefit? Is there a side effect profile? And going through your list of what you would be doing for deprescribing and optimizing takes what looks like a very benign list and helps you
Mhm.
recognize that it can cause so many issues for our
Yeah,
elderly folks. Well, awesome. The other thing
absolutely.
for me, Donna, is make sure you guys buy MedStrong and read it.
Mhm.
It's fantastic. I've had several colleagues just tell me it is the best book they've ever encountered when it comes to
Mhm.
deprescribing, and I can't agree more. I need to grab my copy here really soon, Donna. I will send you my address right after this.
Yes.
And then the other elements, I guess, to make sure you guys know about is Donna is on RPH Ally, rphally.com. Join us there and jump in her deprescribing channel to offer some of
Yeah.
your insights and get some from her.
Yeah.
Any parting words for you,
Share your
Donna?
stories. Just share your stories on the webs on the channel. Would love it. We all
Love
have them. There's many of them. I see them all the time, every time I log in, unfortunately. So join in and share your stories too.
Love it. Love it. Hey, we can all get better together like that. Everybody have a
Yeah,
wonderful rest of the day, and we will talk to you next week.
sounds great. Bye, everyone.